I'm Dr. Andrew Armstrong at the Duke Cancer Institute. I'm an associate professor of medicine there. And I'll be presenting today results of our automated bone scan index analysis, which is a phase 3 analysis in men with metastatic castration-resistant prostate cancer. I'm presenting these results on behalf of my colleagues at Memorial Sloan Kettering, Johns Hopkins, and Exini, which developed the software for this analysis. So essentially, men with metastatic prostate cancer have a predominance of bone metastases, yet measurements for how to define progression and response in the bone are really lacking. RECIST responses, for example, only capture soft tissue disease. The automated bone scan index is a software program that reads in a typical bone scan, which is read by nuclear medicine radiologists, and interprets the bone scan using the software to assess the bone burden of metastases. So essentially, the numerator is the amount of bone lesions on the bone scan divided by the total amount of bone on that scan. And each individual can be quantified in terms of a number, a quartile as a continuous variable. And in this trial, we did a phase 3 analysis of this automated bone scan index. The basis for this analysis was a phase 3 global international randomized trial of an immune modulatory agent that unfortunately did not improve overall survival, but was a rich data set that included bone scans on all patients. All patients had bone metastases, and they were all followed for overall survival. When we enrolled this trial, this was a prospectively defined biomarker endpoint of the trial that was approved in the IRBs of these trial populations before the data was available. In this analysis, we had over 1,200 men contribute data to the study, and the vast majority of them had bone metastases that were valuable for this analysis. Our primary findings were that the bone scan index, as measured by the Exini software version 2.0, was highly associated with overall survival. So the increasing burden of bone disease was associated with a more rapid decline, not just in overall survival, but in symptomatic progression, skeletal events, radiographic progression, particularly in the bone. And that this was highly reproducible and was validated based on our phase 2 results. So this is the largest study ever of the automated bone scan index. It really validates earlier work showing that this is an important prognostic variable. We show that it's independent of other prognostic variables, so that has clinical utility in defining prognosis in this disease state. And so going forward, what do we do with this? This does not remove the nuclear medicine radiologist from clinical care. We regard this as a complementary biomarker that's quantitative, that can be measured over time, that can update a patient's prognosis, that can be used perhaps as an endpoint in clinical trials, which is more quantitative than the previous versions, such as defined by prostate cancer working groups. We regard this as complementary to soft tissue measurements with CT or MRI, so this is really just imaging the bone scan with all of its limitations. For example, bone scan flare, which can be seen as a healing reaction to effective hormonal therapies, you can actually see increases in the bone scan index while a patient's responding. So as we define progression metrics for the bone scan index, that will have to be taken into account, and we actually have a poster presentation on such a use of the bone scan index as an endpoint in clinical trials. So at this point, we regard this as a quantitative biomarker. It's used in a software program that can be done very quickly as part of clinical practice. It could complement the existing radiographic report of a bone scan, and this could be used for clinical trials, both for eligibility, stratification, eligibility in terms of risk, as well as bedside prognosis to help a patient understand their life expectancy and when disease may progress.